Thanks for joining. My name is Elizabeth Skoy. If we haven't had the opportunity to meet, I see a lot of familiar names and faces joining us today. I'm the director of the Center for Collaboration and Advancement in Pharmacy. And through a collaboration with the North Dakota Board of Pharmacy, we are working to hopefully get all of the pharmacists and technicians and anyone practicing in the state up to speed on some new prescribing authorities that just were put into place early this year, so early in 2026. So we are going to be recording this webinar, so you should have already gotten a notification that this will be recorded, and we will be posting a recording of this on our CAP Center YouTube page, as well as we will be providing an opportunity for you to get handouts. So we're hoping to have, and Lisa's putting a link to our YouTube page, as you can see here in the chat. But we're also going to be providing on our website a link to the handouts. You'll be able to see the handout that we have for the slides today. So no worries if you don't necessarily have to take frantic notes. We'll get that handout, as well as we do have a copy of the prescriptive authority, the new legislation as written, that the North Dakota Board of Pharmacy inspectors have been handing out as they've done their inspection visits. So if you haven't gotten a copy of that as well, there'll be an opportunity for you to request a copy of that, and we can email that to you. So some resources coming your way. So this webinar is really just to give, again, an overview of the new prescriptive authorities so everyone kind of has an idea of what the opportunities are in North Dakota. And then also at the end of this, we're hoping to take some time to hear from you, either via the chat or you can unmute and we can have a discussion as to what it is that you think you might be able to need or questions you might have as it pertains to your pharmacy and the practice of pharmacy in the state. We also have the executive director of the Board of Pharmacy, Mark Hardy, is on here as well. And he has agreed if questions arrive that I can't answer, I want to defer to him, he will be able to get back to us on that as well. So without further ado, we're going to go ahead and start the presentation. So give me one moment as I get my screen shared here. Okay, so hopefully you should all be able to see my screen. We are going to, again, start off. So the title of this presentation, we are not going to be having continuing education for this. I wanted to get this delivered in a really short period of time. So we do not having continuing education, but there might be additional continuing education opportunities in the future as we go forward. So the title of this presentation is Expanding the Pharmacist Scope, New Prescribing Opportunities in North Dakota. So before we get started, I just kind of want to go over the different opportunities for prescribing for pharmacists that we have in North Dakota. So the first is collaborative practice agreements. So just as a refresher, and for some of you, this might be old news. If there's any students that are on here, if you're a P3 student, I'm actually going to be lecturing on this next week. So this will be a refresher for you. But collaborative practice agreements are between a pharmacist and a provider. So in North Dakota, providers are nurse practitioners, medical doctors, or DOs. And in the collaborative practice agreement, the prescriber, as listed previously, delegates a task to a specific pharmacist or pharmacists. So it could be one pharmacist or it could be a group of pharmacists at a specific entity. And for the most part, these tasks can be management of medications. So for instance, initiating medications, modifying medications, stopping medications. And some examples of collaborative practice agreement have been, one of them is the collaboration that we've had with the North Dakota Pharmacy Service Corps. You probably have heard of the opportunities that they provided last year with a number of collaborative practice agreements that were available to pharmacists across the state through a platform that they had as Element. So if you are utilizing a collaborative practice agreement in your pharmacy, if you're initiating or starting a medication, that medication is under the provider's name. So it'd be under the name of the nurse practitioner, medical doctor, whoever it is that you have that collaborative practice agreement with. So another prescribing opportunity that we have in our state is through a protocol. And so protocols are typically set by an institution, or for us, it would be like the State Board of Pharmacy. And they provide the pharmacist the ability to prescribe medications through that statewide protocol. And they usually it's typical in protocols. They'll state, who it is that can participate in that protocol, as well as they might say different stipulations as like types of training or continuing education in order to participate. And if a medication is prescribed or initiated under a protocol, that medication would be prescribed under the name of the pharmacist that provides it. So the rules and laws in North Dakota do allow for the North Dakota Board of Pharmacy to initiate protocols based off of public health issue. So some of these are that we have in our state, for instance, are immunizations or tobacco cessation or any other issues that are deemed appropriate by the Board of Pharmacy. And the language that we have for that in North Dakota is specifically listed here. So some of these you probably have already used in your pharmacy setting, but some of our statewide protocols that we have in North Dakota where pharmacists can prescribe are immunizations, naloxone, or I should say opioid antagonists, as well as tobacco cessation. So those are three examples that we have in North Dakota for statewide protocols. So more recently, in January, there was an emergency legislative session that did change the prescribing opportunities for pharmacists in North Dakota. So a couple of these authorities, one is with this new legislation, pharmacists have the authority to order labs or provide any CLIA-waived tests. So if you can remember before this, we had a list specific of CLIA-waived tests. The board really did a great job of keeping up to date to make sure that we were able to prescribe as many or order or deliver as many CLIA-waived tests as really were available. But this is just a blanket that we really can provide any CLIA-waived tests in our state now. As well as we have now been allowed prescribing authority for a number of other opportunities, which I'll get to in a moment. There are a few stipulations for this. For one, you should be educationally prepared and competent. And I really appreciate how the Board of Pharmacy and the legislature put this, where they didn't list a certain number of continuing education hours or certain type of credit or anything like that that you needed. It was just that it's really on you. It's that standard of care for you as the pharmacist to ensure that you are educationally prepared and competent to prescribe what it is that you're going to be prescribing. You also have to be physically located in North Dakota when you're prescribing those. You should have a relationship with the patient. And so, again, if you're at the pharmacy and a patient comes into your pharmacy and you're talking with them, you have established a relationship with them. You also should make sure that you obtain adequate information on health status. So the type of information you're going to be collecting is going to vary based off of what it is that you're prescribing. And we'll get to that in a little bit. So some types of things you prescribe, you might need to collect more health information, and obviously other things, maybe not quite so much. So here's just a kind of a word cloud, if you will, of the different types of prescriptive authorities that we have in our state. So, and we're going to go through these in a little bit more detail, but overall, pharmacists can now independently prescribe. So that means not through a protocol or not through a collaborative practice agreement, but independently prescribe short-acting beta agonists, medications to treat hypoglycemia, medications for Lyme's disease, cold sores, lice, travel medicine, epinephrine, HIV PEP, influenza prophylaxis, influenza treatment, SARS-CoV-2 or COVID-19, motion sickness, and group A strep. And then if those that have asterisk by them are annotated that, if the patient is symptomatic and has a positive CLIA-waived test, that's when you would have the authority to prescribe medications to treat those. So we're going to go into each of these or classes of these in a little bit more detail. So these are the medications or drugs that we have prescription authority for. So HIV post-exposure. So post-exposure, non-occupational post-exposure. So if you have someone who believes they've had exposure to HIV, you can initiate HIV PEP medication. We also have short-acting beta agonists. So you can prescribe a short-acting beta agonist for a patient that has diagnosis of asthma. They should have had a prior short-acting beta agonist prescription, and they should also have a current prescription for a long-term asthma control. So under those stipulations, you can prescribe a short-acting beta agonist. Also, you can prescribe medication for travel medicine. And I will note that there's quite a few pharmacies across the country, and this is becoming more and more popular, where pharmacies have made a very robust business model out of this, where if somebody is going to go on an international excursion, they typically want someone to meet with them and go through their different medications that they might need. So that might be not only vaccinations, and we already have a protocol that allows for us to provide travel medicine vaccines, but this is, in addition to vaccines. So things they might need for malaria prevention, or things that they might need for, if they're going to certain areas and, maybe for altitude sickness. So this is, there's a lot of accredited, or not a lot, but there's quite a few different accredited programs that are out there that you can take to get a travel medicine certificate. And I actually have my travel medicine certificate, and it's not incredibly onerous, and it's really, in fact, very interesting. And there's excellent resources from the CDC as well as other travel medicine providers that allow for you to do this in a really robust way. Another prescription authority opportunity is for emergency situations. So again, if someone's in an emergency situation and needs immediate care for like a short-acting beta agonist, epinephrine, or diphenhydramine, in those emergency situations, you can prescribe those medications. And then as well as antimicrobial prophylaxis for Lyme disease. And that is per the CDC guidelines as to when you would prescribe that and for which individuals. So anytime that you are prescribing one of these, as well as some of the test to treat options that I'm going to be getting into here in a little bit more, you should have a patient assessment protocol. So that's one of the stipulations in the prescriptive authority when we're prescribing a medication. Now, this is just for medication, like drugs and drug categories. This does not apply to devices. So when you're providing a patient a medication, or prescribing, I should say, a medication, you should always ensure that it's based on the current clinical guidelines and best practices. And then in your protocol, you should have patient inclusion criteria. So that means who will you prescribe for? You should also have patient exclusion criteria. So are there certain patient populations that you might not feel comfortable prescribing, where you would maybe refer to a higher level of care? And then when would that be where you would determine that somebody needs a medical referral criteria? So for every medication or drug category that you're prescribing, you would just want to have something outlined. Almost, I think of it more of like a standard operating procedure of how you will actually proceed with this in your pharmacies. Also, when you are looking at particular medications, you're going to want to look at with the prescriptive authority, you're going to want to identify how you would incorporate a follow-up care plan. So what are the different monitoring parameters that you'll be looking for? When would you want to have that patient follow up with a pharmacist or their primary care provider? And then you also should ensure that you've tried to obtain if the patient has a primary care provider or a provider of record. So you should inquire about that. And then if they have listed one, you should notify that primary care provider or provider of record within 3 business days of the prescription that you have provided. So that's if you provide a prescription. And then if you have a test result, if applicable, and any prescription associated with it. So if somebody comes in for a strep test, they test positive, and then you prescribe the appropriate antibiotic treatment, you would then want to ensure that you are following up with that primary care provider if listed, letting them know about the encounter. And then you're also going to want to maintain appropriate documentation. So just justification of that, of what you did and why, provider notification, and any care plan. This is really in alignment with what we're seeing, obviously, in medicine across the board. So when we are prescribing medication, we're initiating medication, we're assessing patients, we should have the appropriate documentation to follow up with that. So I'll just take a few moments to get into the assessment protocol. So what might that look like? So let's say that you're pharma, and this is just an example, and I'll kind of talk through as to things you might want to change. Also, at the CAP Center, we are hoping to develop some of these assessment protocols and having these on our website for you to be able to utilize and manipulate and edit as you see fit as to your own pharmacy. So let's say that in your pharmacy, you are offering strep test to treat services with the prescriptive authority to prescribe appropriate treatment if somebody tests positive for strep. So in my assessment protocol, I would have eligibility for service. That's a requirement. So who is it that I would be, um, treating? And so here would be, eligibility in my exclusion criteria. So I will refer people, so I'll definitely, test people if they are, you can see at that second bullet point or second part there. So anyone that presents with the sore throat and have group A strep household exposure, I would test them. I would also test anyone presenting with a sore throat and have two of the following criteria that are in alignment with clinical guidelines. Then above, I have the eligibility for service. And who would I not? So this would be my exclusion criteria. So at my pharmacy, I might say any patients that are pregnant, I'm not going to feel comfortable test to treat with them. I'm going to refer them on. At pharmacy, I might say anyone less than 3 years of age, and that's in alignment with strep guidelines, really uncommon to have strep in anyone less than 3. Your pharmacy might say less than 5. Right? So it just depends again on what you feel comfortable, and it should be in alignment with guidelines. Also, anyone temperature with greater than 104, I'm going to be referring on. I wouldn't want to I would say that they need an elevated level of care. And then I'm going to also be checking their respiratory rate. So anyone greater than 20 breaths per minute. So those are the eligibility for service that, is this example that this pharmacy would have. Now, your pharmacy might be a little bit different. You might also want to check blood pressure and have that listed, or you might also want to include, maybe a different temperature. Maybe you want to go down to 103 or 102. So kind of will depend again on your own pharmacy, but it should definitely be in alignment with guidelines as well. So then I have who it is that I would be prescribing for. And so if upon a positive rapid antigen detection test or RADT, then this is my treatment options. And again, this is in alignment with current strep A guidelines. So we have our first line and then our alternative treatment options listed there and our duration. And then I also have my follow-up plan. So I have here that, the patient should be instructed to contact the pharmacy if symptoms don't improve within 48 hours. I also have here that in the event of a negative RADT for a child or adolescent, I may refer the patient to obtain a throat culture. And then if a prescription is provided and a primary care provider is identified, the pharmacy will notify the provider of record within 3 business days. So I have this all listed here. And then this might be an example of what you might collect that would be in alignment with that. And so I might collect any allergies. Again, that would be in alignment with what the patient for antibiotic treatment or any other medications. I might have, if they've had an antibiotic in the last 30 days, any medical conditions that they have. I have them to list a current primary care provider. And then I have them list their symptoms again, which will help me determine whether or not I'm going to be delivering that test. And then I might collect my objective data. This might be some examples of what you might want to collect. Although, again, you would want this in alignment with your protocol, whatever it is that you might be assessing. That I would have it a place where maybe I document whether they have a positive or negative test. Might have a spot where I can document the assessment itself and any information that led me to the decision. And then any follow-up instructions. And then if I made a follow-up phone call, document that here. So those are just, again, it's an example. It does not have to be exactly how we listed it here, but just as an example of ways that you could not only have a protocol of how you would operationalize this in your pharmacy, but also as to how it is that you might document the actual patient encounter. There's quite a few different opportunities out there right now. There's various platforms available. I think even some of the pharmacy dispensing software systems have different areas where you can make care notes or you can have different templates built in. We've also been working with the North Dakota Pharmacy Association. They've had the platform of Element to try to see, we're going to be working with them to see, the templates that might be available as well for documentation. If you're already doing some work with Starfield in the one program or through the ND PERS about the patient program. So we're going to be trying to work with pharmacies for that documentation piece of it. So one other note here, I'm just going to go back to kind of this assessment protocol. I mentioned this here, but for instance, motion sickness is one of them that is this, like motion sickness, either prevention of or treatment of motion sickness is one of the things that we can prescribe. So obviously for group A strep, this is a pretty lengthy assessment protocol. But for something like, scopolamine patches, if somebody's going on a cruise or they're going to be traveling somewhere and they're going to be going through like windy mountain roads and they get car sick or whatever it might be, and they want a scopolamine patch, the assessment protocol might be very different. It might be a lot shorter, right? You're not going to maybe have quite as much of inclusion and exclusion criteria. You might not have as much assessment that you need to be doing. So again, you might not have as much follow-up with the patient, right? It might be just a lot more brief and it's going to be a lot more straightforward. So again, understanding that it really depends upon what it is that you want to be prescribing within your pharmacy and what that might look like. So just, if you want to get a head start on this before all of these protocols, we're going to have some templates for you from the CAP Center. If you want to get a head start on this and start prescribing today, you definitely can. It's already allowed by the state, but I want to just kind of point that out too. So moving on to, and then I missed one slide here, just to go back. So back to the plan. So this might be another part where your document plan, and maybe you have a checkbox for other things like supportive care that the patient could do at home as well. And this is probably similar to if you've ever had like a care notes or an after visit summary from a provider, things that you kind of talked about the visit and all that. And it's very similar to what you probably are already familiar with. So now we're going to move into the therapeutic substitution. So these are the available therapeutic substitutions that are available through the state for prescribing. So these are things that would just kind of be in its own category for therapeutic substitution. You wouldn't necessarily need like the protocol for these, but this would be an example of what it would be excluded. So for instance, antidepressant, antipsychotics, chemotherapy, scheduled true controlled biological products, and that does include insulin. We've had confirmation on that. And then narrow therapeutic index drugs. So those are excluded in the prescribing authorities. Everything else is something that we could go ahead and have a therapeutic substitution for. So an example might be like oral contraceptives, right? So if there's a therapeutic substitution for one brand versus another, we know that sometimes insurance companies or maybe availability will insist, payment of one versus another. Then that's something that you could go ahead and do a quick just substitution for. As well as others that aren't listed on the excluded list. There are some requirements with the therapeutic substitution, so you should discuss it with the patient. So letting them know that this is what was prescribed and you would recommend or going to open and offer the opportunity to do a therapeutic substitution and kind of letting them know, the reason that is. So, if it's an access issue, if you can't if you don't have that in stock or, it's a baby on back order or something like that. And then also you should also discuss the cost benefit with the patient. So if that medication that you're substituting to is a cost savings, letting them know that, but also the flip, if it happens to be more expensive because it's maybe an access issue, to have that conversation with them as well. And they should be approving of that therapeutic substitution. And then you should notify the provider within 24 hours just to let them know that that therapeutic substitution has taken place. That's another prescriptive authority that we now have within our state. And this will hopefully save pharmacies a lot of time. I know that sometimes there are certain things, obviously, that are covered versus others. And granted, the exclusion list does take a chunk out of that, but it does get us in the right direction to be able to hopefully free up some of these things and to have those therapeutic substitutions done at the pharmacy level rather than contacting the provider and waiting for them to get back to us. All right. Also, we do have the authority to prescribe various devices. Again, these are devices, these aren't drugs or drug products, so we don't need that whole long protocol. So the devices that we are allowed for prescribing authority are inhalation spacers, nebulizers, disposable diabetes blood sugar testing supplies. So, and also pen needles. So we get the prescription for the pen, but we don't get the prescription for the pen needle. How many times does that happen? Well, guess what? We can now just prescribe the pen needles. We don't need to contact and wait for the provider to get back to us on that. Same thing with disposable diabetic testing, blood sugar testing supplies. So patient is just charged with the meter kit, but they don't get the any separate written for the strips or lancets or anything like that. We can go ahead and we can write a prescription for those. And then auto injectors, like for instance, for anaphylaxis or allergies is another device that we can prescribe for. Okay. So we're going to open up here to questions in a few moments, but just wanted to kind of let you know of some ways that the CAP Center is hoping to assist pharmacies in our state as they start implementing these things. We're also hoping for potentially some real health transformation funding that's going to be coming out. You have that notice here as a bullet point, but talking about how we can collaborate with the Pharmacy Association as well to maybe potentially initiate funds for pharmacies to maybe start these services, to be able to implement them. So looking for opportunities there. And a lot hasn't been released yet by the states that would fall into that bucket, but we're keeping our eyes open for that. We already mentioned how we're going to be having some protocol examples on the website that you could edit to your liking as to your pharmacy is what fits your pharmacy, as long as it's still obviously in line with clinical guidelines. And then one thing I will say is Medicaid credentialing is really important. So if you are prescribing any of these medications for a patient that is on North Dakota Medicaid, remember that you have to be credentialed as a provider under North Dakota Medicaid. So we have at the CAP Center, we've had a lot of different resources that have come out as to how to get credentialed for North Dakota Medicaid. We've had actual training sessions with North Dakota Medicaid where we've kind of walked people through how to get credentialed. So if you are somebody that still has not done that, this would be a really good time to get the ball rolling with that. And so we have our email address in the next slide at the end of this presentation, as well as our website. And so you could contact us if you're wanting to get information as to how to get credentialed in North Dakota through Medicaid. Other resources, guidelines, and specifically I want to point out this infectious disease prescribing reference guide. Emily Perry, who is our antimicrobial stewardship pharmacist through the CAP Center and works across our state, has really worked hard with Haley Warner, who was a APPE student on rotation, as well as MP, Masters of Public Health. And they developed this fantastic infectious disease prescribing reference guide. It's these little booklets. I just have the picture of it here, but it's a little booklet that's bound together. And we have the actual guidelines for cold sores, SARS-CoV-2, HIV, PEP, influenza, lice, Lyme's disease prophylaxis, and strep throat. So if you're somebody who's kind of wondering like, oh, where those guidelines are, or, gosh, it's been a while since I reviewed those, we have these little guidebooks here. A lot of you that were at the North Dakota Pharmacy Convention in Minot this last weekend we had these out and a lot of you took these. If you would want one of these mailed to you, please contact us through the website or through our email address, I should say, that is in the next slide. And please email us and let us know that you would like one mailed to you, or if you want a couple copies mailed to you, and we will work to get those sent out to you. Just provide us with the mailing address you would like those sent. Also, we are going to be providing some CE links for you. So we're not going to necessarily be doing continuing education on every one of these. But for instance, we will be kind of coming together with links for travel medicine, for instance. So if you're like, gosh, I'd like to maybe look into getting my travel medicine certificate or doing that accredited program that the board requires for that particular prescribing, we're going to be having some CE links for you where you can investigate those. As well as test to treat resources. So strep, influenza. If you're someone even who wants to start initiating test to treat, but haven't yet done a CLIA waiver at your pharmacy, we can help with that. And then of note, we've kind of been doing a little bit of pushing through the CAP Center website through a physical assessment continuing education. Some of these, particularly if you're going to be doing the test to treat, for instance, SARS-CoV-2 or influenza or strep, there are some physical assessment components, nothing, outlandish, but some basic physical assessment that we should be doing and documenting at the pharmacy. And so we have a on-demand recorded webinar that has CE that you can just do that portion. So you could just, if you want a refresher and you want to see the videos of, how to do a strep throat and culture and how to do, nasal, and you want to watch the videos and have that basic information provided to you, you can do that continuing education and document that. But then after you've done that and you're like, you know what, I would like a little bit more hands-on training. We also are going to be having a hands-on assessment workshop in Fargo. And we had one in Minot last weekend. We're going to be having one here in Fargo towards the end of May. And then this is also an opportunity at the end of this, where we'd love to hear from you if there's anything else that you think you could use to help implement these. We'd be happy to help you with that. And then last but not least, as I promised, we do have our CAP Center website up here, as well as our CAP Center email address. So you could, again, if you want a copy of the handout more urgently than before it goes on our website from the recording, or if you want a copy of the Board of Pharmacy's new prescriptive authority document, we could email those to you upon request, as well as that chronic disease toolkit reference book. We could send those out via mail to you as well. So those are some resources that we have now. Medicaid credentialing or anything else that comes to mind, or questions after today. If you, after watching this presentation, you have a question, feel free to reach out to us and we'd be happy to work with you and answer any questions that you have. So with that, I am going to pause sharing of my screen. At the end of this, I can put our email address back up there as well and website, but just kind of opening it up to the chat or any questions that anyone has. I'm gonna look through the chat here. So, and that is correct. So from and Mark Hardy, you're listening, so correct me if I'm wrong, but we had a question in the chat that said, just to clarify that Novolog switch to Humalog is excluded. And that is correct, because it is considered a biologic medication.
Yeah, that's correct. Yeah, that's correct, Liz. Thanks for the question. And great to see everyone on here. But the Biologics Act federally, when that was passed, of course, that made insulin a biological product, given the molecule size of insulin. And so therefore, that's why it's in there. And of course, the standard in the state perspective, there is an interchangeability standard, right? So it's a little different than just a simple substitution that can be made. That's why they exempted that out of the law. But to kind of build on your question a little bit, obviously there's a lot of opportunity there with that therapeutic substitution to make some very impactful patient care decisions in pharmacies, right? So, I mean, everyone is aware of situations coming out of the hospitals, patients coming out of the hospital, and of course, one drug not being covered, them not that you have a ability to therapeutically substitute the other similar drug for that. So, maybe changing dosage forms, changing, like your example there, the asthma medications to a different long acting steroid. So yeah, there's a lot of opportunity there to make a lot of impact on patients, insurance coverage issues, so on and so forth. So yeah, just I guess to bite on that question a little bit and just add a little context. But yeah, feel free to think widely about what your opportunities are with that and your abilities to impact patients.
Thanks, Mark. Any other questions? Kind of pause. You can unmute yourself, raise your hand if you want, or it doesn't look like anyone's, or utilize the chat feature. So the question is, what documentation for prescribing and or therapeutic substitution do you see necessary for sufficient for insurance billing auditing purposes? So I think there you have two categories there. So you have the basic prescribing and then you have that therapeutic substitution. So for the documentation for the prescribing, I think is really following just the regulations of what it is that you need to be documenting as to like the justification as to why you prescribed and what it is that you prescribed. And then as well as it requires, depending upon what it is you're prescribing, potential information that would be relevant to the prescribing of that medication. So again, if you're prescribing something like, antibiotic after a positive strep test, you're going to probably want to be collecting information on like allergies, potentially weight, especially if it's a child, those types of things. Whereas it might be a lot less if you're doing collecting something for like a scopolamine patch. So I think as long as you can, have your documentation as why it is that you did what you did, or if there's a positive test or justification for that medication, and it follows along with your assessment protocol of who it is you're prescribing for. I think that's the most important part. As for therapeutic substitution, I'm not really sure about the insurance billing or auditing purposes, and we can talk about that, if there's anyone else that has any thoughts on that. But I would say definitely if you can somehow document the justification as to why that is. So for instance, those key parts that we just mentioned in the handout or in the slides of that you've had a discussion with the patient, so the patient approved the substitution, that the reasoning behind that. So was it an access issue or was it a cost benefit? For instance, if the insurance company only covers one, that should be a pretty obvious change there in documenting, and there shouldn't be too much of an auditing issue with that. As well as then that you've notified the provider. So I think those would be the most important pieces to document somewhere, whether that's on the prescription itself or the prescription of record, whether it's electronically or somehow in the patient's chart, if you have that in the pharmacy with like a care notes or something like that. And two, just to note that if anyone's having issues or anything comes back from insurance providers, or they're getting into any snags in the road after you're doing this, we definitely want to know about it. So please reach out to us, let us know, because we want to kind of hear what's happening and then seeing if there's ways that we can help alleviate that or help others who might be running into that issue. That's a good question. Oh, that's a good question. Mark, you can let me, I would say that if you're doing a therapeutic substitution, that would go then under your name because you would be the prescriber of record, and he's nodding his head. So yes. So if you're making the therapeutic substitution yourself, again, you're not contacting the provider, you're just making that. And then with that justification, you would then be the one prescribing. Let's say that patient is on North Dakota Medicaid, and you haven't yet been credentialed by North Dakota Medicaid, so you need to make that therapeutic substitution. Then at that point, you would need to contact the provider who does have that credentialing to get that substituted. But hopefully, like I said, everyone gets credentialed for North Dakota Medicaid, and they can make that decision themselves. And then that would be under you as a prescription provider of record. Good question. Yeah, Nathan, you got a question?
I do. I have a comment and a couple questions. First of all, I really enjoyed the physical assessment CE that you guys put out. It's definitely worth your time. I learned a lot and is a good refresher.
Thank you.
My questions, first of all, would you consider CGM sensors to be disposable uh, diagnostic devices that could be possibly prescribed, like test strips, you know?
The disposable
Ooh.
ones.
Yeah, sometimes
Yeah,
we
like
have
you know what you mean, like the 14
they,
day or
yeah, and
the
they
10 day.
run out of refills,
Yeah,
and sometimes it's a kind of a desperate situation. Could we prescribe a replacement
because it's
sensor
a
for them
testing.
under
Yeah.
that device law?
I'm going to
I'm not
default to the executive director of the Board of Pharmacy. What
Yeah,
do you think, Les?
that's a great question, Nathan. I think so. I think you could make a case that that's a disposable testing supplier. That's how
yeah,
I would look at it. I think the goal was actual machine, right? That was
right,
what they were looking to exclude. So,
right,
I mean,
correct.
I think
That's a
there's definitely a basis to say that that is a disposable testing machine, not a machine, but a testing supply. So,
sensor. Yeah,
yeah, yeah,
it's for continuation of existing therapy. So
I agree.
that's kind of what I was thinking too, but just wanted to clarify that.
Yeah.
Also, I'm curious if you're recommending any signed patient consent before we do this test and treat. We do it for vaccines. We have them read the statement and sign before we vaccinate. I don't remember doing that at doctors' offices before they see us and treat us, but
Yeah, I think you do. I think you do a blanket when you go to the doctor's office, but I
yeah,
think it's one of like the one things you sign every year that's just like a blanket, I consent to treatment, that type of a thing.
okay.
Um, and yes, I would say absolutely. So, when you have for instance, like if you have that intake form that I showed you, have
Hmm.
like, physical assessment and all of that, and the, health history and allergies, I would definitely have a spot in there where the patient consents to being tested and then, treatment if applied, if appropriate.
Hmm.
Yeah.
Okay. And
So,
then just the last thing, you had asked if there was any other information that might help us. I think maybe some suggested supply lists. I didn't really know when I
great.
started shopping what sorts of things I should start shopping for to set this program up.
Yeah.
Do we need red biohazard bags? Do we need
Mm.
little mats to put on our counters? Do we need a certain type of stethoscope? Because there's a bunch of different kinds of stethoscopes out there.
Yeah, right.
That kind of stuff. And then also, if there was a resource where we could find simple patient information handouts to go with, like, say, strep
Mm,
or influenza treatment, just the little handout that you can send with, kind of like you get at a doctor's office post-visit.
perfect. Absolutely. Those are great.
All right. That's all I think.
I love those. Thank you.
Thank you.
Um, and then also I had a question. When you make the therapeutic substitution, would the amount of refill stay the same or the amount prescribed stay the same? And I would say yes, those two things would stay the same. It would just be the therapeutics. They're just substituting only the medication itself. Mark's nodding, so feel good about that answer.
Yeah,
Um,
that's right. Yeah,
yeah,
just and I think that's exactly right, Liz. And obviously you'd have to adjust things according to what that therapeutic substitution is. Like if you went from a weekly pill to a monthly pill, you would need to adjust things there. But the refills and what the intent as far as duration would stay the same.
perfect. So let's see if there's any other questions anyone has. These are really great questions. I'm sure others are having these same things that people are asking. Well, if anyone, I don't want to make everyone stay on too long necessarily just to listen to the silence, but we're really hoping that this is something that is taken up by pharmacies across the state. A lot of the changes and the reason that this was changed was due to the rural health transformation funding that's coming federally to North Dakota, as well as a number of other states across the country. The scoring criteria, depending upon how much money each state got, was directly related to, in some terms, like how pharmacy friendly that state was. So the amount of autonomy that pharmacists were given with related to test to treat, prescriptive authority, as well as ability to provide a CLIA wave test or just lab tests in general. And so I really commend all that worked on this legislation to get this up and going, as well as the legislature for passing this and making this available. And now it's really time. I'm just gonna kind of give our motivational speech here just for a few seconds, but it's really our time at this moment to take this opportunity and to provide access to care for our patients. That's why this is here, because we are in a rural state and access to care is an issue for patients, not only in rural areas, but also some urban areas. And so by allowing us to do some of these things and having more autonomy, it's going to hopefully be the number one thing is to serve our patients and to give them better access to healthcare and to make it easier for them, but also it's a potential for additional like service opportunities, revenue opportunities generating for your pharmacies as well. So, and we're hoping that, we can be good stewards of this opportunity, show the state and our legislators and, obviously the board who's big supporters of us already, but that, we're willing and able to do these things. And it might open up, we're hoping it might open up even other doors maybe down the road. So we just want you to know that we're here to assist you if you have any questions or want additional support or great ideas. Thanks, Nathan, for sharing those. I made notes of those. Those are really good. And if there's anything else that anyone thinks they might need, we'd love to hear about it from the CAP Center. Okay. So with that, I will close off today. Hope everyone has a really great evening. Thank you so much for joining us. And if you want to watch a recording or see the handout, those will be posted on our website shortly. So thank you. Take care.